Committee on Health Services. For folks don't want you to have to stand in the back of the room, overflow is the next room over, room 131. So you're free to go in there and hear the proceedings. Roll call, please.
Senator Rocky Adams. Senator Byrd. Present. Senator Carroll.
Here.
Senator Douglas.
Present.
Senator Herron. Senator Mills. Senator Nemes.
Present.
Senator Rawlings.
Present.
Senator Tishner.
Present.
Vice Chair Richardson.
Here.
Chairman Meredith.
Present. Do you have a quorum and do the constituted business? We're going to have a slight change on our agenda and hear from Dr. Stephen Stack, Secretary of Cabinet for Health and Family Services. So, Doctor, if you would, please come forward. No, it's not your first time here, so you know the routine. If you would, introduce yourself for the record and feel free to proceed.
Sure. So I'm Stephen Stack. I'm the Secretary for the Cabinet for Health and Family Services, and thank you, Mr. Chair, and congratulations on getting such a great turnout at 8 in the morning and for holding a committee meeting at a proper working time. So thank you. So I get to talk about the Rural Health Transformation Program, and I'm going to use some slides that Dr. Langfeld, who's our Commissioner for Public Health, used at one of the budget committees a couple weeks ago. I'm not going to dwell on this, but this is the timeline. It's been brisk. So July 4th, H.R. 1 was signed into law. Then a series of events unfolded. We were given 6 weeks. Every state was given 6 weeks to write a very complicated proposal and submit it. All of us did submit it, and all of us got funded. When we got our notice, before we got our notice of funding, in end of November and December, we had a negotiation period with the federal government where they asked some follow-up questions, and we had to refine some minor things. And then we were notified just before the end of the calendar year in 26 about our award. And then January and the very early part of February was budget refinements, and I'll talk about that in a minute. And we now have our final and full award, and we are now able to move forward. I want to thank the folks represented here on this slide. There are probably more, but this is a good sample. We had very little time, as I mentioned. We solicited people's feedback. The organizations represented by their logos and names here submitted input or feedback, some of whom we spoke with directly and personally, and many of whom we'll work with now as the work begins to go forward. So thank you to our partners, our universities, our healthcare systems, our clinicians, and many others. So thank you so much for that. We were told, all states, to submit a hypothetical budget for $200 million. It doesn't matter now how we got to the money we got. It's been done. It's a now known fact. But part of it was competitive and part of it was not. We outperformed. We were given $212.9 million, which we've rounded to 213 here. So we received $213 million. We were the 11th highest funding of all the 50 states. There's some criteria that were outside of our control, how rural your state was, and they use certain metrics to define that. And so a state, if you look down there, Connecticut, Rhode Island, they're very tiny and not tons of rural spaces. So they were going to get less money just based on the way the methodology was designed. But anyway, we're very satisfied that we got the 11th highest award in the country. So we're going to have 5 initiatives. So the first one, and these are not in order of priority, it's just there were 5. One is maternal health. One of the biggest challenges is going to be the actual delivery of the child. So the maternity ward part of this is the hardest because the financial difficulties of sustaining delivery units. But we're going to start working the year before and the year after, roughly, the pregnancy. So one of the best things we can do, not maybe the best or the only, but one of the best things we can do is ensure every woman who is pregnant gets access to timely and high-quality prenatal care. And we know that as much as 15% of Kentucky women who are pregnant don't get reliable or consistent prenatal care. So we're going to do our very best to try to improve that. If they have good quality prenatal care, it's a higher likelihood they'll have a healthy baby, a healthy delivery, and both mother and child will do better. On the other end of the journey, once the child is born, there are a number of issues that are important in that first year of life. Healthy parenting, healthy nutrition, a variety of things for which there are difficulties, but also for which there are programs and supports. So like the Women, Infant, Children program, the WIC program, the HANDS program that we offer in the state. There's a number of good services and supports. So the goal is to try to support Kentucky women so that when they are pregnant and deliver their children, they have the best possible chance for a healthy pregnancy and a healthy early childhood. And I hope by working from either end of that continuum to the point that's in the middle, that the communities that come together will be able to think creatively about how do we sustain maternity care, for the delivery moment, which is obviously its own challenge. Another issue is going to be, and we've given little labels, so the other one's powering maternal and infant health, and the power part of the powering is an acronym that stands for something. From crisis to care, integrated EMS and trauma response, we're going to try to work on how do we increase our workforce, particularly for rural communities, for EMS, EMTs, so that people, when they need help and call for help, someone can show up, that there's adequate workforce, adequately trained. And then when people need to be transferred from a smaller community to a bigger community for care, are there the resources needed to actually effectuate safely that transfer? I think the answer today is no, we're not there. And so this was identified across numerous commenters when we solicited input as an area of importance. And so we're going to work on that. Rapid response to recovery. So the empath model and mobile crisis. So this is mental health. So we have a unit operated at Eastern State Hospital by the University of Kentucky that is essentially an emergency evaluation and stabilization unit specifically for behavioral mental health, addiction, and other related conditions. I'm an emergency physician. I'm very grateful for that. It was a wonderful big part of my 27 years of my life training to do that and then doing it. But general purpose emergency departments are not the optimal place to take care of people in behavioral health crisis. They're loud, they're chaotic, they're disruptive. If you come in and you're in distress, a place that's more calm, more assuring, and that gives you the opportunity to kind of settle into being receptive to the care and the treatment that can be provided and that has behavioral health experts is really, really much preferred. The empath unit does that. Now there's 20 plus states in the United States that operate empath units. We didn't create that, others did. But UK, working with us at Eastern State, put the first unit in and it's been very successful. So we find that in that 23-hour period, we can stabilize people, get them more receptive to the outreach and the suggestions that people offer, and hopefully then get them into dedicated behavioral health follow-up, which gives them a better chance to get on a path to recovery and get back to productive and fulfilling lives. So we're going to try to replicate that across the state in a regional model, which will mean we'll have to work with community partners, FQHCs, other hospitals, behavioral health community. And by bringing these communities together around very specific problems to solve or projects to work on, we hope those communities will also be able to foster other solutions that we weren't able to conceive at the time we put this proposal in. Item number 4 is rooted in health. I think we all know that we have, unfortunately, one of the worst oral health statuses in the country. It's tough. We don't have enough dentists. We don't have enough hygienists. And those are difficult challenges. It's hard to create dentists and physicians. Their training is expensive. It's very long. And it's just not enough of them and hard to get them to go to low population density areas. But maybe we can find ways to increase the number of hygienists and with the use of telehealth platforms and hub and spoke models, project preventive care, screening care, and perhaps even some measure of restorative care out to communities that currently have a great deficit of that. And of course, designing this in a way that people who are both uninsured and are on Medicaid can get access to high quality oral health care is going to be an important part of this. So we're going to work on that as one of our 5 projects. And the 5th one is, they call it Rural Community Hubs for Chronic Care and Innovation. The first use case we're going to start on is, I think of it as kind of a continuum. I don't know if I could fully substantiate that as I describe it, but I think I largely can. If you're physically inactive and you don't eat well, you can get obese and develop metabolic syndrome. If you do those things, you can slide into prediabetes, type 2 diabetes, and have those issues. Now you start having additional medical problems, and if it progresses even further, you get outright diabetes and you develop other complications. The goal, and I know that this is in alignment with some of the things that I hear coming from the legislature, is can we push our population more to the left to healthy eating, healthy activity, thereby preventing entirely or forestalling or markedly delaying that disease progression. So that's the first chronic illness continuum we're going to focus on. Food as medicine is a big part of that. The Hospital Association, Department of Ag already work on a food as medicine initiative. And food as medicine has specific meaning in certain contexts. I'm using it in a very general context. I think even Steve Jobs said at one point, treat your food as medicine, or you'll be treating your medicine as your food. And I think had an example like a handful of pills to take. So hopefully we can make progress with that and working with our community partners. In all of these, we're going to try real hard to work with local community leaders, local healthcare providers, because I think, we can talk about it conceptually in Frankfort and at the state. We can try to organize structures to make things happen. But ultimately, where the rubber meets the road is in the individual interactions in local communities in a way that's consistent with their resources and consistent with that community's needs and sensitivity. So this will not solve all of our problems. I'm not deluded. But I do think there's an opportunity here to really do some meaningful work over the next 5 to 6 years and hopefully sow some seeds that will yield fruit beyond the life of this grant. I only have 2 more slides. There are focused priorities that this grant challenges us to do. We have to emphasize transformative things. It's not doing the same things and just supporting them economically. CMS has been very, very clear. They expect us to think outside the box and be innovative, not just support the existing status quo. It's a 5-year transformation, so it is time limited. I will just say, as you all legislate, I wish we could do a little bit less of the boom-bust funding. Federally is a big challenge, but it can happen a little bit here where we get a splash of money for a short period of time and it's hard to move really fast and build things sustainably. This COVID was a good example of that. I think we're now in a situation with the rural health transformation that's kind of similar. If you're going to transform all of your healthcare system in some really big ways, it's kind of hard to get up to speed. By the time you get up to speed and start making progress, the money runs out, which is another part that all of this has to be sustainable. They've challenged us to make sure everything has a plan for how do you continue after the grant money runs out. Early wins are critical, so we're going to have to try to get up to some kind of takeoff velocity quick and show that we can achieve some milestones. But the really bigger benefits are going to happen in the out years as we get up to scale and have things established. And this is a unique grant. We are at risk to have to pay it back. So folks, I've said in settings, and I will when I interact with folks and community partners, we sincerely want to partner with as many folks in the community as are on point for those topics as possible. But we are on the hook. So we are approved not to do whatever we want. We're approved to do what is specifically described in our 63-page application. We have to do things in there. We can't do things if it's not in there. So if anyone, this is being seen by some as the new golden calf or the new golden egg that's been laid for vendors and others to try to get a piece of their pie. That's not going to happen, because if we just give money out and we don't deliver on the objectives in the grant, CMS will rescore us every year and come back and say, well, you didn't meet these milestones, so you have to pay that part back, even if we've already expended it. So we really are on the hook to try to tie this directly to those things that our project officer and we have agreed are our outcomes and our metrics. So it's not meant for unsustainable ideas. So, like one of the things I've used as an example, this is not a pot of money. There may be examples where it could happen, but in general, this is not a loan repayment program, because if you start a loan repayment program, you have to have money to continue to do loan repayment after it ends. This is not that. This is a one-time splash of money, not an ongoing resource. It's not meant for more of the same, and it cannot replace or duplicate existing funding sources. So when I've said very starkly, just because I know you have to hear things 7 times for it to sink in, and sometimes you have to be more direct than you want to, so it's clear. This is not a rural hospital bailout fund. It absolutely is not. We cannot just give money to rural hospitals to support services that are going to suffer funding losses because of other parts of H.R. 1. They were very clear that that's not allowable and not part of this grant. There's some limits and exclusions. We can't do new construction. We can't build a new building, but we could renovate, softscape the interior of a building. So say we want to do a new empath unit at a hospital, and the hospital has 5,000 square feet or 15,000 square feet, but it needs to be renovated, we could give them some money up to limits to take down walls and reconfigure the place so that they could be used for a different purpose. We can't pay clinicians salaries. We can't do independent research and development. So like we can't go fund a drug company to go do research on a drug. We cannot just replace EMR. So we couldn't go and say, we'll buy an EMR for everybody. Now there's limited carve outs, like in a certain circumstance if you did it, but it's very, very specific. In general, we can't do that. And we cannot duplicate billable services. So if there's some other pay, it's a payer of last resort, and that's the case for Medicaid and Medicare. They're payers of last resort in a way. But in this, it's even more. Like you cannot just go, if there's a CPT code or an ICD codes and hospitals and doctors can bill Medicaid or commercial insurance or Medicare, we can't pay for that. So that is the end of the slides. One thing I would also just share real quick, and then we'll be over to you, Mr. Chair, for questions, is on the website, I would encourage anyone who is interested in this program to go to, see if it pops up here, the Rural Health Plan. I'm sorry, the angle here is terrible. ruralhealthplan.ky.gov. So ruralhealthplan.ky.gov. And if you come here, this has started. It'll be a work in progress. Again, all of this, we're having to build a team and get up to speed. But as we get up to speed, you can read our full application up here on this tab on the left. You can see the notice of award that we were given for our funding and the terms we have to adhere to. This is a description, this Understand Rural Health, about the data we used and the inputs we had to sort of get to where we did. Get involved, and we're going to, let me see if this is improved yet. No, it's not. We got to fix this. So when you scroll down in here, there's a link at the end of one of these paragraphs. Here it is right here. We got to make it more obvious. But if you click on that, you can fill out a short little form, give a little information about how to reach you and who you are, a nonprofit, a clinician's office, something like that. And you can sign up for updates. And as we start to do RFPs or release other information, we're going to try to push those things out so people are aware. And when we do RFPs and stuff, we'll put them up here on the web page, which we don't normally do on our websites because the procurement stuff happens out of other facets of state government. But we'll put some of that up here so that people can find it and know that there's opportunities. You guys have already reviewed one of our first contracts. We're going to work with the Foundation for a Healthy Kentucky, and that came before GCRC just recently. And so we're going to work with them. That's going to enable us to get staff hired through them in ways that we can move quickly to get stuff started. But it's exciting. It's a huge progress, or a huge task. You will see Dr. Langfeld, the Commissioner for Public Health, presenting on this, and me alternatively, just because we both have a lot of other things. So we'll tag team these kind of presentations, but we are in regular contact. So, Mr. Chair, thanks for the opportunity to be here today. And I am happy now to address whatever questions the committee has.
Thank you. Appreciate the update, and I want to congratulate you on the award and the Herculean effort that went into this to get us where we are. I certainly appreciate that. It was quite a momentous occasion to receive that, and we're very proud of that. We talk about rural health transition, but this is both rural health and Medicaid transition, since so much of our rural population is relied upon Medicaid. And I think this gives a unique opportunity to restructure that program and rural health care as well. So look forward to that. Several members have questions. Senator Berg, you're first on the queue.
Thank you, Mr. Chairman, and thank you, sir. Honestly, I was really excited to get up and dressed and here this morning because I wanted to hear this presentation. Okay. I'm very proud of the work that you've done. I'm proud of the award that Kentucky got. I personally am excited about some of the things that we're looking at. You know, you and I both have worked in level 1 trauma centers almost our entire life. And being able to integrate healthcare delivery throughout this state is something that for me, I've been dreaming of, not replicating, not duplicating, but the fastest, easiest, best way to take care of a patient. So thank you, I'm excited. I do have 2 concerns based on your presentation that I really want to address to my committee members. One is prenatal care. We've had a case now, came out last week in Tennessee, that passed a law similar to one that we're contemplating here in the state, a medical conscience law. And now we have a pregnant woman in rural Tennessee whose OBGYN is refusing her prenatal care because she is not married. She is literally having to leave her state to see an OBGYN. So that is something I want to warn us about. Second thing I really think is really important is we're talking about dental care. And we have bills coming through this session that would make fluoridation in our water optional, which I can understand. I can understand people wanting personal choice. On the other hand, it decimates our children's teeth to take the fluoride out of our water. And we do not even currently have a system in place to take care of them as it is. What is going to happen is going to be extremely detrimental. So I just want to put that out there. Thank you.
Senator Carroll, you're next in the queue.
Thank you, Mr. Chairman. And Dr. Stack, appreciate your presentation. And this is a huge opportunity for this state to make some significant impacts. You spoke a little bit about the team. The structure that you have, are you breaking staff up within each segment of what the proposal encompasses, and you'll have teams for each segment to work on that, or what is the basic structure that you're putting together within the cabinet?
So I'll describe it. I believe that there's actually a diagram in our application online, so people can look at it if they want to. So each of these, think about it creating a new company, and there's 5 verticals, and each of these 5 enterprises or activities are going to have a small little core team at the state that's going to help coordinate and facilitate. The real work, though, is going to be done with that team overseeing it and coordinating, but then getting the partners in the local communities who are going to then have to actually do the work. And so there'll be a project director and a deputy director. And just, again, to put this in context, I don't know the exact numbers off the top of my head, but Department for Public Health is somewhere in the ballpark of $520, $540 million a year agency. And this is $213 million. This is like adding half again, the amount of work. So it's not going to be the existing public health team. They will contribute because they have knowledge and expertise, but there's going to have to be others who oversee this to be accountable and have it get done. So we'll have a director and a deputy director. We have someone who's going to help with the IT side of it, someone who's going to help with our engagement and relations with the various partners. And then each of the teams are going to have, there's a small number of positions described that's the same across the 5 different areas. And that core team is going to be the ones who then work with all the rest of the partners to kind of convene and get stuff done.
Okay. Mr. Chairman, one quick follow-up, please. There is obviously a chance of a new administration in a couple years. Is that something you all have had discussions in? It's going to be critical that this continue on seamlessly, and I could see that being a pretty major obstacle if there were new members coming into the cabinet. What do you anticipate happening should there be a transition and a lot of turnover within the cabinet? And I'm not trying to get rid of you at all, but that's just a political possibility in Frankfort.
I think my wife liked a vacation, so it is not it's not lost on us that there will be a transition. So we'll be this is year 1, next year will be year 2, and then there'll be a transition in year 3, 4, and 5, and there'll be a runoff year, for part of year 6, as we're allowed to spend money into the 9 months of that final year. So all of this right now is build a team, get it up to speed, and get moving forward. Historically, when administrations change, even when they change parties, people beneath commissioner level typically stay on and continue to do the work. I mean, so program staff and career servants typically continue on and do that work. So there will be a robust team overseeing this work. A solid foundation will be set, and there'll be plenty of opportunity for whoever comes in as the governor of Kentucky and the team that they build to then take that last 3.5+ years to work on there'll be a chance to modify within the parameters of the application. They're stuck with the 5 things we picked, but within that, there's still some latitude for how you sustain it and move forward. And then federally, there'll be a transition throughout this grant, right? So there'll be some change at the executive branch federally. But I think the timing aligns well enough for this to be able to go through those smoothly, in my view.
Thank you. Thank you, Mr. Chairman.
I would note, too, that, as I mentioned earlier, this isn't just about rural health, it's about Medicaid as well. And I think having the Medicaid Oversight and Advisory Board will be very important to us in that transition period. I think that's one of the best pieces of legislation that we passed in recent years, because we'll have some continuity in that area. But appreciate Commissioner Stack availability to us. You've done a great job. We appreciate that, as well as your people. Commissioner Lee does a great job, and we continue to look forward to working on these initiatives. Senator Richardson.
Thank you. Also, Dr. Stack, I just want to say thank you. This was quite the endeavor to pull together, and so I want to thank you and your team for the diligence in doing so. You touched on it a little bit while I was formulating the thought, is usually how those things go. But the RFP process, would this be direct contracts or open for vendors to compete for the opportunity to serve under these?
Right. So there's going to be a number of them that are going to have to be open competition, because if you need a software platform, or if you need certain kinds of services, that you have to go to the open market, and so we'll post formal RFPs and people have a chance to compete for it. We have 2 large universities in the state. Those 2 large universities we use for a variety of things, because they make it possible. One, they deliver in the clinical arena a lot of care to a huge proportion of our folks, and they have outreach stuff already built in. So we'll work with our universities. So for some of those things, or like FQHCs and nonprofits like Foundation for a Healthy Kentucky, some of those we'll use the procurement paths that are available to work with them, which don't always require open posting for some of the things. But the big stuff, the stuff that others would kind of compete for, like if we need vendors to help, like we have a contracted consultant who's helped us with project management for getting the application in and all. Well, those are all competitively procured. So we have to get access to that kind of service, we have to competitively procure it. So it'll be everything in compliance with what the procurement rules require. And I would say not any different than we've done for our routine operations, but a lot of these things will be posted publicly.
Senator Douglas.
Thank you, Mr. Chairman. I actually have 2 questions, if I may. Dr. Stack, I also want to thank you for the hard work that you and everyone that you worked with have committed to this project. Those of us in the healthcare space really recognize what a huge bite of the apple this really is. It really is. But with that being said, whether we're looking at the urban or the rural health transformation, whether we're looking at urban or rural, and whether we're looking at Medicaid or the Rural Health Transformation Program, my first question is about a receiver accountability model. Because my big concern, and we made this huge mistake with Medicaid years and years and years ago, I want to know kind of what incentives have been discussed to include or hold the receivers accountable for their level of health care. Because one of the things I've learned over time is that the health care that you and our colleagues in medicine provide is not meant to keep people healthy. It's meant to maximize their health level. It is up to them to keep that. So I want to know kind of what kind of conversations have been had or you expect to be had in the area of receiver accountability. And I can either let you answer that, or I'll be happy to fire the second one at you.
I can take them both, and I can answer them both at the same time.
Okay. The second one, and this is a serious question, how do we not punish our healthcare system when we treat the non-compliant patient? We know that there are going to be patients that are compliant, but when we have non-compliant patients, we tend to bash our healthcare system. And we talk about we've got to continue to create more and more and more opportunities when you and I and every other person who's treating patients know that we have a myriad of opportunities, but we don't have the conversations about whether people are going to access those opportunities or whether we're going to hold them to some kind of an expectation to participate in those opportunities. We don't have those conversations. And in order for us to have a healthy healthcare system here, not just in the Commonwealth, but in our country, we've got to start having those conversations.
Well, thank you, Senator Douglas. So on the receiver accountability, the way that the grant notice of a funding opportunity was written leaned on this concept of OKRs, outcomes and key results. And I try not to promote different, can't remember the name of the book, but I know the author. So a gentleman named John Doerr, Doerr, wrote a book, and he describes this methodology, outcomes and key results, or OKRs. So it's sort of a way to define what are the objectives you're going to accomplish very concretely and achievably. That's the methodology that was referenced in the notice of a funding opportunity and the methodology we used. So for accountability, it's going to be, if we give you funding, here are the metrics these are the yardsticks we're going to have to report to the federal government to achieve in order to demonstrate we have fulfilled the work we said we would do. So the accountability here will be, do we actually deliver results? So we're going to use...
I'm sorry, Mr. Chairman, but the accountability that I'm talking about is the receiver accountability. I don't mean the healthcare system accountability. We already do that.
The citizen or
The citizenry or the patient. I'm sorry, I wasn't clear.
I get you. I can't say that is specifically in here. So the recipient of the funding is going to have accountabilities for us to design systems. But now that I understand that better, let me take that and merge it to the second thing you said. So I agree that we have to be very careful not to design systems that punish clinicians for doing the best they can and following guidelines, and others exercise their right to autonomy and don't comply or don't adhere, and those are different words, and then we have different outcomes. On the other hand, I like to think a little bit differently. There's a video I used to use years ago when I was in other leadership. There was a video of an escalator going up from a metro stop somewhere, and everybody got off the metro and went right up the escalator. And then they took the stairs that were next to it that no one used, and they turned it into a working piano keyboard. And so when you walked up the stairs, it played tonally correct musical notes. And then when they showed the videos after that, it was like 80% of the people walked up the stairs and kids were bouncing and playing music. I tend to subscribe to the view we have to make the desirable thing the preferable thing. We have to make the desirable thing the easier thing. If you go into a grocery store, it is alarmingly too easy, and I'm guilty of this too. I guarantee you that I'm not the only one, that to walk down the center aisles and buy processed foods, which have all sorts of challenges with them. Much, much harder and often much more costly to go around the perimeter and buy fresh fruits, fresh vegetables, poultry, eggs, things you have to cook and prepare. In this, I think we will be attentive to how do we design systems where the individuals we're trying to help and have benefit from this have the opportunity to have resources to make good choices, but then that the good choice is one that's the palatable choice and the preferable choice. I've never really been a fan of the stick approach. Sticks are needed sometimes. They have their place. But I think if you incentivize people and then create the conditions where they do the thing that's more desirable, that's preferable, because then they have agency and they have choice and they're much more likely to be enthusiastic about it and follow through. I think in many ways I agree with the general premise of what you're saying, which is how do we have individuals exercise accountability? And part of that, I think, is we have to attend to, have we built a world where that accountability is desirable and possible for many of them?
Thank you, Mr. Chairman.
I have a couple of questions for you, Dr. Stack. each of these pillars are obviously important. I commend you for structuring in this manner. But is there one that you think deserves higher priority than another? I'm not trying to do a catchy here. Just
You're asking me to pick my favorite of my 5 children, right? I think all 5 of these problems are of enormous impact. I mean, look, if you have terrible teeth or you don't have teeth, you have health implications, but you have social implications that are every bit as big, right? Like it or not, pretty people get hired more than people who aren't as pretty. If you don't have good teeth, it's hard to get jobs. I mean, so it has real implications for people being self-sufficient, sustainable. So like oral health is hugely important. For maternal health, you'd have to look really hard to find a pivotal moment in time, which is the months leading up to delivery, and those early months, that will have more impact on whether that human being has a chance at 70 to 90 years of productive and fulfilling life than those 12 months, right before and right after the birth and the birth itself. For behavioral mental health, we still have a horrible addiction problem with overdose. Well, wonderfully, enormous decreases, enormous. But the levels they've decreased to are still killing more people in the United States than the whole Vietnam War did over the whole course of the war, each year. So in obesity, I mean, we are one of the most, unfortunately, overweight and obese states in the whole country. And when you have close to 2/3 of our state who have, physical inactivity and are overweight, so I appreciate the question, and I feel like, in a way I'm openly skirting it, but it's because I think all 5 of these things, and the EMS part, if you had to pick one that is more tactical in a way, it might be EMS. The other ones are really big population health. The EMS part is simply, we don't have what we need to make sure that when people do have a crisis, they can get where they need to get. And so that's maybe more concrete, like solve a smaller problem in a way. But the other 4, I think, are really sweeping population health things. And I would observe one other thing. This is not a Medicaid project. And I hear the part about Medicaid plays a huge role in the health of our population. No dispute there, Senator. But this is in public health because first and foremost, it's about how do we improve the population's health. And so that, I think, I'm very happy that that's where we put it. Of course, I had no small influence in that, but there are other states who have done that, but not all, because we're administratively set up differently.
Well, I'm hoping you would point out that one in particular, the EMS situation, because the recent statistics is that 92% of our counties are ambulance deserts, and that certainly impacts healthcare. But I know that doesn't stand alone. We got to look at all these things. But I appreciate that. Appreciate you being here this morning. Very informational, very insightful, and look forward to the next step in this process. And I'm sure we'll have numerous conversations for this committee as well as MOAB. But thank you for making yourself available to us today.
Thanks, everyone. Have a good day. Bye-bye.
Only other agenda item is Senate Bill 74. Co-Chair Richardson. While he's coming to the table, failed to give folks an opportunity to recognize any guest you might have today. Does anyone have anyone they want to recognize? Seeing none, then Senator, the floor is yours.
I'll back up and just take a moment of privilege to recognize some guests. Sitting behind me, you'll see some youth, young adults here in support of this bill, and we'll be making their rounds to the Capitol today and to protect our kids, Kentucky's Kids Day today on the Capitol, and then also we have some doctors with the Kentucky Medical Association Day today as well. So I just want to welcome all of them for being here and their support.
I appreciate that. If you would, please formally identify yourself for the record as well as your guest, and we'll proceed.
I am Senator Craig Richardson, representing the 3rd Senate District in Kentucky.
And I am Doug Hogan, Government Relations Director for the American Cancer Society Cancer Action Network, ACS-CAN.
Before we get into the details of the bill, Mr. Chairman, there was a committee sub on this bill. And
Second.
Thank you, and I'll explain that committee sub briefly in this. Senate Bill 74 is a simple common sense measure that ensures the settlement dollars from the litigation against Juul are used for their intended purpose, and that is protecting Kentucky's youth from the harms of vaping. This bill creates a vaping settlement trust fund in the state treasury to hold proceeds from the Commonwealth's case against the Juul Labs. It does three, I think, straightforward things. First, it directs these funds exclusively to Kentucky's Tobacco Prevention and Cessation Program to support youth prevention and cessation efforts. We just heard a detailed testimony on the Department of Public Health, and that's where this will be housed, as they already are doing these things for youth and all tobacco cessation across the Commonwealth. Second, it ensures the funds are distributed to support ongoing public health work, and then it allows these unused funds to be carried over to continue the work in this program. At its core, this is legislation that is about accountability. Those companies that were involved in these misleading practices and where litigation found that they had liability, they should all do their part to allow these funds to go to the education of these youth. And it's not just the education of the youth are part of the teaching process. They have peer-to-peer support programs that these funds would give them more resources to help each other. So with that, happy to entertain questions, but respectfully ask for your support on this bill.
Excuse me. Before we go to question, we have a couple of people who have signed up to speak, I believe, in support of the bill. If those individuals like to come to the table, I have Miss Delana Crump and Cassia Miller. There's him. Thanks for joining us this morning. If you would as well, make sure your green light is on for your microphone. Pull it close so folks will be able to hear you. If you would, please introduce yourself for the record.
Morning, Mr. Chairman. My name is Ksenia Miller, and I'm currently a junior at Villa Madonna Academy and a member of the Youth Advisory Board.
Good morning. My name is Delaney Crump. I'm a student at Boyd County High School, and I'm also a member of the Youth Advisory Board.
Welcome. Glad to have you here this morning. Please proceed.
Thank you. I first want to thank you for this opportunity to testify today in support of Senator Richardson's bill, Senate Bill 74, to direct Juul settlement funds to youth nicotine use prevention and cessation programming. In recent years, and with the legislature to thank, there has been tremendous progress towards a nicotine-free future for all of Kentucky's youth. That's why we continue to see declines in the use of products like e-cigarettes among young people in our state today. Still, the percentage of Kentucky middle and high school students who use any nicotine product, but especially e-cigarettes, remains double the national average. We all know that a new generation of youth like me, and even those much younger than me, have been addicted to nicotine and are being targeted by the marketing of these dangerous products, intentionally lured by fun colors and fruity candy flavors, and enticed by cool devices that now even include smartphone and gaming features. Here's what else I know. Every day, I see students in my community using nicotine products, e-cigarettes, nicotine pouches. They use them all, and they use them all the time. Students have been addicted to these products because they were marketed as an outlet for stress. Because advertisements with influencers near our age were regularly shown to them on social media, and most of all, youth use these products because they were strategically targeted by this manipulative industry, because Juul wanted us to vape. That's the sad truth, but that is what happened. And now our students are underperforming in school because they're sneaking out to bathrooms to vape, unable to be the athletes they once were because their damaged lungs can't handle the activity. And they're facing a mental health crisis because Juul promised us that these products were exactly what students like Delaney and me needed to relieve our stress. I wish I could sit here today and ask you to help fix this issue by solving the youth nicotine crisis just in Kenton County. But unfortunately, this is not an isolated issue. Every school in every county is impacted. There is, however, something we can do about it, and I'd now like to invite Delaney to share with you all exactly what that is.
Thank you, Ksenia. I want to echo her thanks to you all for allowing us to share our stories and advocate on behalf of all the Kentucky youth this morning. Just as Ksenia said, this issue knows no county lines. In my school, I see exactly everything Ksenia described as occurring in Kenton County. Students have been addicted to these dangerous products by an industry that uses deception as their primary marketing strategy. That is why there's zero doubt in my mind that the opportunity that each of you have to help move forward Senate Bill 74 is an important one. In 2022, Kentucky decided to help address the youth nicotine use crisis by joining a multi-state lawsuit against Juul for marketing e-cigarettes to kids, where we won a $14 million settlement. Those payments come into Kentucky over several years, but so far they have not been directed for the purpose that they were intended to, which is to help educate kids on the dangers of nicotine use and support those who are ready to quit using nicotine products. Now is the time to allocate the remaining annual Juul settlement funds to support youth struggling with nicotine addiction and to prevent kids from ever using those products in the first place. Kentucky will receive just over $1 million per year for the next 3 to 6 years, and directing this money to youth education to prevent first-time use and to support kids who are already using to make it their last is the intended and the best use of these funds. Thank you, Senator Richardson, for introducing Senate Bill 74 to make this allocation happen and ensure the remainder of these funds are spent on which they were won for. And thank you, Mr. Chairman and members of the committee, for hearing our stories and supporting Senator Richardson's bill. Simply, we're asking you to do what you know is right and take advantage of this opportunity to vote yes on a bill that will help protect Kentucky's kids for years to come. Thank you.
Thank you for your testimony and your leadership on this. We do have one question. Senator Carroll.
Thank you, Mr. Chairman, and ladies, thank you for being here today and giving your testimony. Senator, are there other lawsuits that are pending against other manufacturers, and are there any provisions in the bill that would address any future settlements that come along?
Any settlement that may come that is under this umbrella, so not just Juul Labs, they were the largest named defendant. There were others involved in the settlement, but any settlement that's under this that can come through, not that we're anticipating any now, would then fall under this umbrella at that time. But there's an anticipation that this money will have a trail-off effect.
And you know, as a country, I almost think that some of these folks they budget in lawsuits and anticipate that it's coming, but they make enough money that it's just part of doing business. And until we put some teeth and some serious punishment into some, like the THC gummies. I mean, and you all have heard me talk many times about the number of pediatric ingestion fatalities and near fatalities with these products, and they're made to look like candy. And you know, and the lawsuits come and they pay it, but you know, they keep moving on. So I'm not sure we do enough at the federal or state level to control these types of products, and you know, companies are just looking at it as the cost of doing business. Thank you, Mr. Chairman.
Thank you. Senator Herron.
Thank you, Mr. Chair. Thank you all for your testimony. I don't know if you all have the answer, or if Senator Richardson, you do. How are we currently using those funds right now in the state?
Those funds are currently going to the general fund. There's no specific account that they're going into. They're just going into the general fund to be spent on general fund things.
Thank you.
Is there a motion on the bill? Motion, is there a second? All in favor will aye. All opposed will vote no. Clerk, please call the roll.
Senator Rocky Adams. Senator Berg.
Aye.
Senator Carroll.
Aye.
Senator Douglas.
I would explain my vote, Mr. Chairman.
Yes.
Thank you, Mr. Chairman. I just want to express some concern that I have in the healthcare space with the use of the word addiction. Often we throw addiction out like it's just an everyday usage, but in the healthcare space, we look at addiction, we look at dependence, and we look at habituation. And my concern is that every time we label someone as being addicted, we take away any expectation that we have for them to participate in their rehabilitation. We essentially do. I'm not telling you what words to use, but most of what we're talking about here is a dependence or a habituation. And if we're going to get a real good grip on what's going on in our substance use disorder space, I really am begging people, let us use the right vernacular in the right words to describe the conditions that we're really talking about. Thank you, Mr. Chairman.
Senator Herron. Senator Mills. Senator Nemus.
Aye.
Senator Rawlings.
Aye.
Senator Richardson. Senator Tishner. Chairman Meredith.
Aye. The vote is unanimous, 10-0. Bill passes with favorable expression. Congratulations, Senator. Ladies, appreciate you being here today to help educate us and move us forward. Appreciate your leadership. Couple of quick announcements before we leave this morning. Our next Senate Health Service Committee meeting will be next Wednesday at 8 o'clock. But as I announced on the Senate floor yesterday, we will have a special called meeting one night next week after we adjourn. It'll be an hour-long meeting, I promise you that. So as soon as we have that confirmed, we'll get that out to you. Just ask that you be prepared for that. We're going to talk about the Rural Transformational AI Care Model, which was the genesis for my Senate Bill 175. Anything to come before the